We are live.
Okay, good evening, friends. Welcome to the PG track program of Delhi CSI, and we are into the 78th webinar after a break from Cardiological Society of India National Conference, which was a great event. Had a PG track program there also, great papers, great presentations. We are back again to the pure academics and for all our PGs. And today we have, in continuation, as all you had desired, a session on dynamic auscultation. And we were discussing with my colleague Girish, we couldn't find anybody better than our most respected Dr. Balachander sir, who's a great teacher, a phenomenal human being, and one of the most sought after speakers. And I would request you to just be very attentive in this particular session. This is one of the sessions that is often asked in multivalvular disease. Generally, you can't stop describing the murmurs and the sounds without talking about dynamic auscultation. So what are the nuances involved? What are the phenomena involved, how to go about it? All these things need to be discussed. So I welcome respected Dr. Balachander sir for this particular session. Along with me on this journey, I have my colleague Professor Girish MP, Dr. Sumod Kurian, and Dr. Nitish Nayak will be joining soon. And most importantly, you all. So let us, without wasting time, hand over the session to respected Balachander sir. So please start the session. In case you have any questions and comments, feel free to write to me in the chat box and we'll take them in the end.
Can I share the screen?
Please, sir.
Just 1 second. Only 1 minute more. Okay. While the slides are coming out, good evening, everybody. Thank you once again, JV Pant. He's my alma mater, to invite me and to deliver this lecture on dynamic auscultation. I was telling that auscultation itself is becoming a forgotten art, and dynamic auscultation perhaps is even more a problem. And the only thing the postgraduates should know is that dynamic auscultation can come as a theory question short note, and also it can play a very important part. For example, I can tell you the scenario of HOCM. HOCM is all about dynamic auscultation because the examiners know that you have a pulse, you have everything else, double apical impulse, everything is okay. But once you present the auscultatory features, then the entire discussion goes for a long time on dynamic auscultation. So dynamic auscultation is nothing but modifying the dynamics by induced or natural mechanisms and assessing the heart sounds and murmurs. Now, for many trained cardiologists, the art of auscultation is difficult to master, and that's why these new inventions have trying to make the auscultation obsolete. But there are still a place in the exam, as far as exam is concerned, that the auscultation and especially the ability to alter the physiology and hemodynamics of the cardiovascular system will accentuate. In fact, in HOCM, more than the dynamic maneuvers, the examiners will ask you, how does this maneuver alter the physiology and hemodynamics of the HOCM? So these things, we will just go in a little bit of detail. There will be some repetition of the slides, but I feel that if you repeat the slides, you're also in a position to grasp what you have not followed in the previous slide. So what does the examiner do? By dynamic auscultation, he is able to pinpoint the circulatory dynamics, more importantly, and also observe these things while auscultation. So remember that auscultation need not be performed in every case. For example, if you hear an ejection systolic murmur, which is in the second right intercostal space, which is grade 4/6, radiating to the carotids, you don't have to do dynamic auscultation at all. Similarly, you don't have to talk about dynamic auscultation where there are large murmurs. You have grade 5/6 murmurs, 4/6 murmurs. You don't have to do it. Then important thing is that you should take the entire clinical picture before venturing into dynamic auscultation. So with these tips, the technique of dynamic auscultation, there are 3 maneuvers: physiological maneuvers, pharmacological maneuvers, and maneuvers that relate to simple change in the posture of the body. And this is a simple slide which tells you the 3 maneuvers: physiological maneuvers, pharmacological maneuvers. It's not a complete list, but physiological maneuvers is Valsalva maneuver, sudden standing from squatting or lying down. It is important maneuver. Mueller's is not so important, but some people still ask for the sake of putting the candidate out of his this thing. Passive leg elevation, sudden squatting, and isometric exercise. So this is not a complete list, but the pharmacological maneuvers are hardly used nowadays, amyl nitrate or methoxamine or phenylephrine. And there are lots of other things with simple postural changes, like going to the left lateral, sitting up, leaning forward. This is a standard phrase all of you will use for describing an early diastolic murmur. And these are the positions during auscultation. The left lateral decubitus, sitting and leaning forward, sitting with legs dangling, standing, squatting, hyperextension of the shoulders, stretching of the neck, etc., passive elevation of the legs, and of course, to hear sometimes pericardial rub. So this is the standard supine. You can approach from the right side and auscultate at the apex with the bell or with the diaphragm. This is leans forward with the breath held, maybe in full exhalation. It is said that you can hear both Graham Steele murmur and AR murmur. Remember, both Graham Steele and AR can be heard, which is not necessarily that Graham Steele will increase with inspiration and it is better heard. And it's the same as AR. And of course, you have the pericardial rub, the knee chest position. Now, what is the hemodynamics of respiration? To start with, respiration is the simplest dynamic phenomenon that everybody does. The important thing is that the right sided chambers, they have an extrathoracic communication, whereas the left sides don't have this. And the right ventricular stroke volume will depend upon the lung impedance. At deep inspiration, you can augment 30% of the venous inflow. So if you want to augment a venous inflow, like you want to hear the typical Carvalho sign of tricuspid regurgitation, you have to have a deep inspiration. This is just a diagram to show you the relationship between the right ventricle and, of course, the inspiration and what the intrathoracic airway does with inspiration. There is a fall in the intrathoracic pressure, which is responsible for sucking the blood. When we come to the second heart sound splitting during inspiration, this is most often asked why the second heart sound splits. The two components can be distinct, and it can accentuate the difference between the right side and left sided murmurs. A normal second heart sound, P2, sounds later during inspiration, simply because the standard explanation is the hangout interval. But simply, if you want to explain, it's an increased blood flow through the pulmonic valve as a result of lowered intrathoracic pressure, increased venous return, and of course, as you know, the hangout interval. Accordingly, the systolic murmurs will increase in intensity during inspiration, and definitely they are indicative of being right-sided in origin. Now, we had this pool data from Rothman and Goldberger, which says that the diagnosis of tricuspid regurgitation can be made out in 61% of cases with deep inspiration. This is a slide which can be kept in your mind. It's the simplest classification of second sound splitting. This is not really dynamic auscultation, but remember, you have to see the split. A normal split is inspiration only split. So when the second heart sound is split only in inspiration, it could be a normal split, it could be a narrow split due to pulmonary arterial hypertension. But remember, if one of the sounds is loud, it makes it difficult to appreciate the split. If P2 is very loud, narrowly split, you cannot really appreciate the splitting of the second sound. If it's an inspiratory and expiratory split, it is a wide split, like in right bundle branch block. It could be fixed, like in ASD, or it could just move. But when the split is only in expiration, in inspiration it is not heard, then definitely it's a paradoxical split. And paradoxical split is the one which always gives a little trouble in severe AS. Remember, it will be on only on expiration. So that is one thing. The second one, this diagram just shows you the normal splitting. We'll skip this. If there's a single second heart sound in, say, expiration, then it is normal, or it could be a narrow split. Remember that the split is too narrow for us to appreciate the two waves. But if the single second heart sound occurs in inspiration, then it's possible that we are dealing with paradoxical split. This is a well-known explanation why pulmonary ejection clicks get attenuated during inspiration, because there is already a doming due to the increased blood flow. In fact, the increased blood flow increases the right atrial pressure, and when the right atrial contraction itself can dome the prematurely open and dome the pulmonic valve. So it does get decreased on inspiration. On expiration, it becomes more. This is also a comprehensive slide between valvular and vascular clicks, which is often asked in the exam. The valvular click pulmonary decreases on inspiration, just with the mechanisms I just explained, increases on expiration. A vascular click from pulmonary will increase on inspiration, but decrease on expiration. The aortic valvular click, which is heard in bicuspid aortic valve, will show no change with inspiration or expiration. And of course, an aortic vascular click, which is heard, can be heard better in expiration. In tetralogy of Fallot, strictly speaking, you can have inspiratory increase of the valvular click. Now let us come to the most important part. This will be repeated again and again, the Valsalva maneuver, which is the physiological maneuver to alter the hemodynamics. And it can give rise to a lot of things in dynamic auscultation. A lot of questions are asked, especially in HOCM. What is the physiological response of the Valsalva maneuver? This, even if you take a little time to understand it, these slides will come repeat again for you to understand. One is that the venous return is reduced due to increased intrathoracic pressure. The stroke volume is reduced due to increased mean arterial pressure during the strain phase of the Valsalva maneuver. And as you know very well, Valsalva maneuver diminishes all systolic murmurs except the hypertrophic cardiomyopathy. And to some extent, we will discuss mitral valve prolapse a little different from HOCM. In a patient with HOCM, the decreased left ventricular volume will increase the subaortic and therefore increase the intensity of the HOCM. And what is the diagnostic value of Valsalva maneuver for HOCM? A sensitivity and predictivity of 96%, a positive predictive of 81, negative of 92%. Remember, the Valsalva maneuver can also differentiate right-sided versus left-sided murmurs to some extent. After the release of the Valsalva maneuver, right-sided murmurs has been shown to return to baseline after 2 cardiac cycles, whereas the left-sided murmurs will take a little bit more time will take at least 3 or 4 to return to baseline intensity. So how is it performed? It is asked by the patient to exhale forcefully. Practically, how do you do it? The patient takes a deep inspiration, followed by forced expiration against a closed glottis for about 20 seconds. We can even place the flat of the hand on the abdomen, provide the patient force, and ask the patient to strain and try to lift the hand. You know that there are 4 stages of Valsalva maneuver, and this is the Valsalva maneuver which the patient is doing. There are 4 stages, but clinically, we have only 2 stages which are important. The first stage is, of course, the just a rise of both the heart rate and the blood pressure because of passive transmission of the pressure. The second stage is the most important, and the 4th stage is most important. The second stage diminishes the venous return and decreases the LV cavity. The third stage perhaps has a lot of pooling in the lung. There is a sudden increase, further drop of the blood pressure, and further, to some extent, further increase in the heart rate. But the last stage is the most important. That's the 4th stage, where there is increased left-sided filling. In the although they say the 3rd stage causes a sudden right-sided filling, but it's not clinically relevant. So you have these 3 things when you are asked about Valsalva maneuver. This itself can be a short note in the exam. You divide that into phase 1, which is not important. Phase 2 is important. Phase 3, again, is not very important. And phase 4, which is the most important. So the heart rate goes to bradycardia in phase 4 and tachycardia in phase 2. The systemic blood pressure has a sharp drop in phase 2 and an overshoot in phase 4. The pulse pressure, which is also important, which is not stressed much, is important. What happens to pulse pressure? It narrows on phase 2 and it becomes wide on phase 4. And of course, venous return is marked reduction in phase 2. In phase 3, it begins to increase, but it normalizes in phase 4. It doesn't increase in phase 4, it normalizes. So you do require intense concentration. This diagram tells you about the normal blood pressure response to Valsalva maneuver in phases 1, 2, 3, and 4. This is the overshoot, which is characteristic. So what happens to the murmur? We'll again repeat it why it happens, because the circulatory change with Valsalva maneuver is a thing which the PGs should know and will be asked in the examination. Obviously, the murmur of HOCM after Valsalva, even after standing, will increase, and after squatting, it will decrease. The murmur of aortic stenosis, on the other hand, fixed aortic stenosis, will decrease after Valsalva or standing, but after rapid squatting, the murmur increases. And this is not stressed too much that the AS increases after rapid squatting. It is not necessary to do also if you have a grade 4/6 murmur most of the times. Now the question is that, is there a dynamic LVOT obstruction? Because if your diagnosis is HOCM, you will say structural heart disease, dynamic LVOT obstruction. So how do you say it is fixed or dynamic? Respiration has no effect on fixed. In dynamic, respiration has changes. On standing, the LVOT obstruction increases. In squatting, it decreases. And in the strain phase of Valsalva maneuver, it increases. So that is the things which you need to call it a dynamic LVOT obstruction. And what happens during the Valsalva straining in hypertrophic cardiomyopathy? I've dealt this first because this is always an exam case. So normally you have a decreased venous return, there is a decrease in LV cavity, there is a decrease in stroke volume, and there is a decrease in murmur. But when there is an HOCM, there will be increased sympathetic stimulation. There is an increase in LV contraction accompanied, and there is an increase in LVOT. So both decrease in LV cavity and increase in the LVOT gradient will augment the murmur of hypertrophic cardiomyopathy. So the clinical implications of this Valsalva, pressure and heart rate response are important. We are a little bit deviating from the auscultation, but the square wave response is seen in conditions like left heart failure, mitral stenosis, and atrial septal defect. So during the Valsalva maneuver, the blood pressure increases, but remains elevated in all stages of heart failure. And this, of course, you know, when the lungs are over. So there is little effect of fall in systemic vascular return on the volume and hence the blood pressure. So you have now two conditions in which you have Valsalva maneuver having a specific response. One is the hypertrophic obstructive cardiomyopathy, and this I've told you that any factor which decreases the LV size, left ventricular and diastolic volume, like decreased preload, decreased afterload, increased contractility, will increase the murmur of HOCM. Now, what happens in mitral valve prolapse? Because this is always confusing between the two. It is said that in mitral valve prolapse, both the leaflet and chordae are too big for the left ventricle. So normally itself, they are in sort of a prolapse status. And when the critical left ventricular volume is reached, it will prolapse into the left ventricle, which occurs in mid to late systole. So the critical achievement of critical left ventricular volume is the most important point for mitral valve prolapse. Click in mitral valve prolapse occurs in mid to late systole because of billowing of the mitral valve and tensing of the chordic tendineae. So murmur usually begins with a click and then fans out to A2. So any maneuver which decreases the LV size or the LV EDP leads to early attainment of the critical volume of the LV, which causes the mitral valve to prolapse early. So if the critical volume is achieved early, it will prolapse early. And once it prolapses early, the click will move closer to first start sound and the murmur will become longer. So this is the point of mitral valve prolapse, which is completely different in its occurrence from the HOCM. So the important thing is what happens in heart failure. We have already discussed this, and these 4 phases, I will not go into the detail. But an important thing is that the onset of straining is important. This slide is just to tell you that in the first 10 seconds, there is an increase in blood pressure, aortic compression due to increased intrathoracic pressure. And this is the last stage is an overshoot, and that is directly due to sympathetic activation. So this is just the slide of pressure and heart rate response in Valsalva maneuver. This is just for demonstration purposes. And this is just a physiological training of the mean aortic pressure. In case you want to draw in the exam, you can use these diagrams to draw. Now, what happens in mitral regurgitation when there is the flow across the mitral valve from the ventricle to the atrium occurs during systole? What happens with Valsalva? The venous return is reduced, the preload reduced, and diastolic volume reduced, stroke volume reduced. Flow between the left ventricle and left atrium across the mitral valve during systole is decreased. So there is a decreased murmur intensity with Valsalva. Most of the times you don't have to demonstrate, but in case they ask in the exam, you can tell that this is the reason why there is a decreased murmur intensity with mitral regurgitation. There is also an increased left atrial and ventricular volumes. Left ventricle is left atrial, and the preload is the mitral valve fails to close completely, and you know that the flow occurs from the LA to the LV. So that's an important thing to remember about the effect of Valsalva for mitral regurgitation. And this is, of course, the blood pressure. Now, one important thing which I forgot to mention is that when you get the Korotokov sounds, especially when you are hearing during Valsalva maneuver, remember, if the persistence of the Korotokov sounds in the phase will tell you that strain phase tells you that there's a increased left ventricular and diastolic pressure. So this is an important point to remember about the Korotokov sounds and abnormal Valsalva response using the Korotokov sounds. Now let us leave the previous slide. That's the same thing. The important thing now is the splitting of the second heart sound after release of Valsalva. So far, we have bothered about the murmur. What about the sounds? Now, what happens? The Valsalva maneuver will damp the blood behind the RV. It will damp the blood during the straining phase behind the RV where you strain. On release of this damped blood, there is an extra filling of the RV for a few beats in contrast to the LV, which, as I told you, can occur. So the S2 split will widen simply because the P2 gets postponed. The A2 also comes a little early and the S2 split widens. But a few seconds after the release of the strain, the split S2 becomes very narrow because the damped blood reaches the LV and pushing a greater volume into the LV and postpones the RV almost to the level of the, A2 postpones the A2 almost to the level of P2. Now, this is an important point to remember that the splitting of the second heart sound after release of Valsalva is a very interesting sign as far as ASD is concerned. When ASD, the atria will act as a single chamber. We'll try to understand, we'll go a little slow on this slide. The atria acts as a single chamber. So any rise in the RAP will also get reflected in the LA. Now, on release of the Valsalva in ASD, any increased venous blood that rushes into the RV will cause more blood to enter into the LV because as you know, for wide splitting, the shunt diminishes. So the left to right shunt diminishes. It will cause more blood to go into the LV. So there is a slight immediate widening of the delayed narrowing of the S2. And this is important thing is to know whether the ASD is closed or not. For example, the wide fixed split of the ASD will remain even after closure of the ASD for some time. But this post-Valsalva effect, that means a slight immediate widening and delayed narrowing of the S2, is an important point. If it happens, that means there is no residual left to right shunt. We don't do it when we close ASDs, obviously. We don't auscultate, but this is a good sign. The post-Valsalva effect indicates the true situation. This is just perhaps only theory, but it's an interesting observation. Obviously, when a patient is getting his ASD closed, you're not asking him to do Valsalva and auscultate, but this is just for the sake of understanding the splitting of the second heart sound after release of the Valsalva and what happens in atrial septal defect. Now, the question is, what is common between squatting and Valsalva? Now, the question is that squatting also causes a raised in SVR, but the venous return is different in the two. The squatting will cause an increase in venous return, and the Valsalva will cause a diminution in venous return. So all the Berbers diminish with Valsalva strain except HOCM. Squatting will increase all Berbers mostly except HOCM. So that is the common between, difference and commonality between squatting and Valsalva. So this is just the venous return, which decreases, causes a decrease in the pressure, and causes these are the physiological changes which will occur in the stage 2 of Valsalva maneuver and its effect on heart sounds and murmur. So it's decreased stroke volume, decreased pressure in great arteries, the A2 splitting narrows, longer Berber, decreased sensitivity of AS and PS, etc. And of course, the change which you've already seen in Valsalva maneuver. This is not so important, the Mueller's maneuver, and this is actually to suck forcibly into a manometer to generate a negative pressure. I don't know, we have not done this practically, but generally speaking, this is perhaps not done most of the clinical situations. But just to say that Mueller's is to inspire against a closed glottis, Valsalva is to expire against a closed glottis. Now this maneuver, unlike Valsalva, will lead to an increase in venous return. So it can increase to an increase in right-sided murmurs, increase in the A2 gap, and can increase RV, S3, and S4. But we have really not done much about this. And the clinical implications are also not very significant for the Mueller's maneuver. So we won't spend too much time on this. And these are the, now let us come to squatting, which is an important thing as far as, again, HOCM is concerned, again, a dynamic auscultation. So how to increase SVR? SVR can be increased by squatting and auscultating the chest immediately. Why? What happens? Kinking of the lower body arteries is probably unimportant. That's an important thing to remember, because in tetralogy fellow, you always say kinking. But here, the effect of squatting on BP is because you are drawing the knees up to the abdomen, and this also has a little effect on the BP. Now, squatting, because of the muscular contraction, can be a form of isometric exercise. So this is a thing to remember, that kinking has a role to play, but it will not increase the SVR. So it is a little bit of isometric exercise which really causes. The important thing is to combine squatting with hand grip, but that will increase the SVR markedly. This is called as squat and squeeze maneuver. You give a towel to the patient, he can try to rinse the towel, wring the towel, or hold it, and he can squat. And this is the best method of increasing an SVR. And if a AR Berber is very soft, you can increase the loudness of the AR Berber with this maneuver, which is called as combined squatting and hand grip. Now, sudden squatting is asked to suddenly from standing position. And remember that we must ask him to avoid the Valsalva maneuver. And this, what does it happen? There is a simultaneous increase in venous return and systemic vascular resistance. Always a question is asked, does squatting increase venous return or decrease venous return? The answer is it does increase venous return. Otherwise, we cannot explain the changes in HOCM. So this leads to increased stroke volume, increased blood pressure, increased LV size, LV and diastolic volume. And this increased stroke volume will cause an increased S3 or an S4. It can louden the Berber of PS, AS, TS, and MS. And it can increase the systemic vascular resistance, which leads to increased louder murmurs of AR, MR, TOF, ventricular septal defect, patent ductus arteriosus. Remember, the squatting increases the TOF murmur. That's how it pushes more blood into the pulmonary circuit and causes relief. Due to comparison of increased preload and afterwards, there is a decrease in the murmur intensity of HOCM. The click of MV is delayed simply because the critical volume reached is delayed, and the murmur of MVP shortens. The time taken for the critical volume in MVP is delayed. So when you take squatting, important is not just squatting. You have to have squatting from standing position, squatting, rapid standing from squatting or lying position. And these two maneuvers have to be done in HOCM. But physiologically, what happens? The effect of rapid standing from squatting or lying down posture is similar to Valsalva. So the patient must be in squatting position for at least a few seconds, and then he is asked to stand rapidly from squatting, and the position and changes are seen in 15 to 20 seconds. In one of the PG track program, they asked how many seconds it takes for these changes to occur. It is 15 to 20 seconds which occur. So rapid standing from squatting or lying down. In fact, some examiners say examiner also has to sit and stand along with the patient. But anyway, that is the important thing is stand, squat, stand. That's an important thing for the dynamic auscultation. So from a standing position, have the patient squat down, bringing the knees to the axillar region. And that's an important thing because you have to produce an isometric exercise, increase the SVR. Auscultate the patient as the patient remains squatting for approximately 30 seconds. So that's why they say that the physician should sit beside the patient. And these maneuvers are best used to distinguish HOCM and mitral valve prolapse. So as I said, squatting will increase the venous return, increases the SVR, diminishes the HOCM, and there is an increased preload which stretches the LV and reduces the subaortic muscular observation. And in mitral valve prolapse, the click moves away from S1 during the maneuver. Prompt standing from squatting or supine position has also been shown to specifically accentuate the mitral valve prolapse, at least by grade 1 in about 74% of the patients. So it's an important thing for squatting and standing. So stand, squat, stand. Sometimes if you want to increase further, stand, squat, and hand grip and then stand. So this is just again the same slide about mitral regurgitation. And this is about the graphic representation of the dynamic auscultation in mitral valve prolapse compared to standing and squatting about the LV size. When you come to dynamic auscultation in MVP as opposed to HOCM, you'll find that the murmur may not accentuate in intensity. That's an important thing to remember, that the murmur does not accentuate in intensity. It doesn't become louder. What happens is that the click moves closer to first heart sound. The murmur becomes more pansystolic. And when it squats, the click moves away from the first heart sound and the murmur becomes short. So typical late systolic murmur can be obtained from squatting. So this is a difference, that where there you will get increase in the intensity of the murmur, here the murmur will remain the same. And this is an important point for differentiation in dynamic auscultation. So what happens in MR, it will increase, VSD, it will increase, diastolic murmur of aortic regurgitation will increase, and hypertrophic cardiomyopathy will decrease on squatting. And this is an important thing to remember, and the circulatory equivalent I have already mentioned. How do you differentiate HOCM and AS on squatting? So squatting for the first few beats diminishes the murmur of HOCM. It causes an increased venous return, a persistent increase in SVR, and once the systemic vascular resistance increases, it holds down the mitral valve, and the LVOT gradient is sort of decreased. But the valvular AS, the increase in venous return, will increase the murmur. In fact, squatting is the most reliable measure for diagnosing HOCM. And auscultation, as I already told you, is the order of squatting first and then increasing. And the patient, I forgot to mention that the patient should not use, should use the right hand for support on the edge of the chair during squatting. But important thing is that the knees have to be drawn into the abdomen. Now let us come to the other dynamic auscultation features. One is the passive leg elevation. This is rarely done, but it is always asked, have you done passive leg? Some examiners are very fond of this passive leg elevation. While lying in the supine position, the patient's leg straight is passively raised to 45 degrees. After 15 to 20 seconds, auscultation is performed and listen for the change. What happens due to gravity? Passive elevation of the leg and displaces the volume from the legs into the central compartment, resulting in increased preload. Because the murmur of hypertrophic cardiomyopathy, is caused by obstruction of the left ventricular flow tract by the anterior leaflet of the mitral valve, the degree of obstruction is lessened when there is an increase in the left ventricular dimension. Now, passive leg elevation also decreases the murmur of HOCM because the increased preload stretches the LV, lessening the obstruction. A decrease in intensity during passive leg elevation distinguishes hypertrophic cardiomyopathy from other systolic muscle with a sensitivity of 85%. But we can also have a passive leg elevation useful for distinct in patients who have musculoskeletal and who cannot get out of the bed. So if the patient cannot get out, he's quite sick, you can do this maneuver. And this is also one of the maneuvers recommended in hypertrophic cardiomyopathy. So this is just passive leg elevation. Now, is there a passive leg elevation or sudden lying down? Now, in this position, what is sudden lying down? In this maneuver, the patient is asked to lie in supine position and passive leg elevation is done straightly. We have said you can auscultate for about 30 seconds. And physiologically, what happens? This maneuver increases venous return, increases the RV stroke volume, increases the LV EDV, and increases the LV stroke volume. This increased RV stroke volume will lead to a widely split A2P2, a louder S3, an S4, a louder right-sided murmurs like PS, TS, and TR. We don't do this much in TR, but it is a very useful maneuver if you do a passive leg rising. The increase in LVEDP, that is the end-diastolic volume, leads to a softer HOCM murmur and the click which will move away with a short murmur. And the increase in stroke volume will lead to a louder LVS3 and S4, a louder left-sided murmurs such as MS, MR, and AS. So all these are possible when there is a passive leg elevation or a sudden lying down which can occur. And this is just to see the physiological changes during passive leg. For everything, there should be a circulatory change and physiological change, which will be asked. So what does passive leg elevation do? It increases venous return, increases RV stroke volume, increases the LVEDP, and then has the effect on the murmur. And this is the physiological effects of sudden squatting and effects of heart sound. The slide summarizes that there is a simultaneous increased venous resistance and increased systemic venous resistance, increased stroke volume, increased blood pressure, increased LV size, and LVEDP. So this is the circulatory changes which occur in sudden squatting. Now let us come to the other dynamic maneuver, which is called as isometric hand grip. And this isometric hand grip is also described as a dynamic auscultation. So what does it do? It increases sympathetic drive, it increases afterload, it increases heart rate, it increases LV volume, and also the feeling pressure. But important thing is that the arterial pressure increase is greater than the heart rate or cardiac output, but they are not always predictable in patients when you do a isometric hand grip. And how do you do? You can, both fists have to be used, simultaneous squeeze, but the proximal muscles, like when you do the deltoid, those things you should not tense. Only the hand grip should be maintained, and 20 seconds is enough to get the hand grip, to get the physiological effects going. What happens to the hand grip and why we are bothered is about the S4. Now, the isometric hand grip, when one squeezes a folded towel, it brings out the S4. Now, the important thing is sometimes a strong hand grip produces local ischemia and generates reflexes purpose to supply more blood. It can even be considered equivalent of having some sort of a physiological distal conditioning. The cardiac output increases through increased heart rate and contractility. It increases the systemic vascular resistance, especially in hypertensive patients. In patients with reduction in cardiac reserve and in patients with severe, with significant obstructive lesions like AS, hand grip has been used widely to bring out the S4 because, presence of an S4 in AS tells you that the gradient is at least 75 millimeters of mercury between the LVOT. So the LVEDP is increased and hence the S4 comes. And the mitral diastolic gradient has been shown to increase as a result of both increase in cardiac output and increase in heart rate. So the mid-diastolic murmur of mitral stenosis can also increase with hand grip. And same thing, to perform the maneuver, you can either ask the patient to squeeze a towel or use a dynamometer, and after 1 minute, perform the auscultatory maneuver. And this is some things which can happen: an increase in blood pressure, increase in heart rate, increase in cardiac output. So MR increases, AR increases, PDA murmur increases. We don't do it, PDA, when it's so obvious. We don't do it, but still you can say. And of course, the ventricular septal defects also may increase. So murmurs that are related to conditions with forward flow like AS and HOCM will decrease with hand grip. So the murmurs of AR, MR, and VST will increase in intensity due to elevation of the aortic diastolic pressures. And detecting an increase in the intensity of the has a sensitivity of 68% only, but specificity of 92%. Aortic stenosis murmurs will decrease in intensity due to a decrease in the systolic gradient, which will result from an increase in the total peripheral resistance. And of course, HOCM will depend upon the volume of blood in the left ventricle. Performing an isometric hand grip increases the peripheral resistance and increases the left ventricular volume. So the murmur observed in HOCM due to outflow tract will decrease when there is an increase in the LV volume. Similarly, this decrease in intensity with hand grip will have a sensitivity of 85%, specificity of 75%, negative predictive value of 95%, and a positive predictive value of 46%. So these are the summary of the immediate hand grip. Impacts the left heart, while inspiration does the same to the right heart. So the difference between hand grip is hand grip augments the left heart, whereas inspiration augments the right heart. And of course, this is the same thing between the hand grip and, of course, the Valsalva maneuver and the hand grip. Valsalva maneuver, standing, increase the murmur intensity, decrease intensity. Hand grip maneuver, passive elevation of the lower extremity, and squatting, each decrease the murmur intensity. So these are some of the summary or revision from what we have told. I won't deal much into amyl nitrate because it's not available, number one. So the pharmacological maneuvers of amyl nitrate perhaps are not important. But sometimes you do get the systemic vascular resistance with nitrates. And the important thing which can happen is amyl nitrate causes an increase in cardiac output, whereas a nitroglycerin causes a fall in the cardiac output. That is what is important. If somebody asks, can you use nitroglycerin instead of amyl nitrate? No, the effects are different. Amyl nitrate will cause an increase in cardiac output, whereas nitroglycerin will cause a fall in the cardiac output. Because this rapid and profound drop in blood pressure caused by the amyl nitrate will result in a strong reflex sympathetic outflow that constricts the veins. But the direct effect of amyl nitrate will open up the capillaries, whereas NTG will reduce the venous return by causing venous pulling. So that's about the amyl nitrate. Similarly, I don't think we should deal with methoxamine and phenylephrine too much because, again, we don't use. Now, this is one maneuver which we don't talk about it much in clinics, but it's very important. That is called as transient arterial occlusion. To perform this maneuver, the sphygmomanometer cuffs are placed on the patient's upper arms, both, and they are inflated to about 20 to 40 millimeters mercury above the patient's known systolic blood pressure. After 20 seconds, auscultation is performed again to listen for changes. The physiologic response is occlusion of the brachial arteries bilaterally increases left ventricular afterload. Transient arterial occlusion increases the intensity of the left-sided regurgitant murmurs by decreasing the compliance. But it has no effect on arterial pressure. It has no effect on the heart rate. It doesn't have any effect on cardiac output. It doesn't have any effect on right atrial pressure. To some extent, you can say it has effect on systemic valve, but then not so. But still, the transient arterial intensifies the left-sided murmurs of MR, VST, and AR. And sometimes when MR doesn't show any change with other things, a transient arterial occlusion can be used to differentiate the murmurs of MR. So that is, now let us summarize or do what is known as a dynamic auscultation algorithm. So dynamic auscultation in diagnosing systolic murmurs. What are the changes with respiration? If it increases, right-sided murmurs, tricuspid regurgitation, pulmonic stenosis. If there is no change with the respiration, it increases with Valsalva or standing or decreasing preload. You perform a passive leg elevation, that is increase the preload if it increases. If there is no increase, increases with transient arterial occlusion or systemic, or isometric hand grip, etc. In addition, it will decrease in intensity with hypertrophic cardiomyopathy. If there is no change in intensity, it is mitral valve prolapse. Remember again, as I told you, the murmur does not change in intensity in mitral valve prolapse. Otherwise, you perform squatting, which increases preload, increases afterload, and you can diagnose the murmur. If it increases in intensity, it's MR. If there is no change in intensity, it is AR and MR. So this is the algorithm to some extent in diagnosing systolic murmur. Now, this is also post-extrasystolic potentiation, which of course is difficult to, only if there are premature beats during the clinical examination, analysis of the changes of intensity and character of the murmur during the post-systolic beat gives important clue to that. And important thing is the intensity of the ejection systolic murmur, as you know, increases in aortic stenosis and hypertrophic cardiomyopathy. Carotid pulse volume increases in aortic stenosis, but remains unchanged or decreases in the latter. This you know very well as a Brocken-Brough effect. The murmur of AR may also increase due to an increased arterial pressure. Tricuspid murmurs also may increase, and the pansystolic murmur of mitral regurgitation will not change, and that is how you differentiate on post-systolic potential. So this is just a revision slide. I don't want to go into great details because it tells you the different changes with the dynamic auscultation in mitral regurgitation, pure severe with papillary muscle dysfunction, slightly different from the, it will help you to diagnose mitral regurgitation, mitral valve prolapse, rheumatic, VST, and the innocent murmur. And this also tells you the effect of physiologic maneuvers on heart murmurs. I think this slide is taken from UpToDate, so it's easily available for all of you to see, those who have access to UpToDate. The effect on respiration, abrupt standing, squatting, Valsalva maneuver, sustained hand grip, and post-extrasystolic potentiation. So it very nicely gives you all the details. And so what are the interventions for altering intensity of cardiac murmurs? One is respiration. Right-sided murmurs increase, left-sided murmurs are louder during expiration. Valsalva maneuver we have discussed. Exercise, of course, is important, but as a dynamic auscultation, we don't do much, but then positional changes, which we have discussed in detail. Similarly, with squatting, we have discussed the passive leg rising. Also, we have discussed there is some post-ventricular premature beat or atrial fibrillation. We have not discussed in great detail, but it is still there. Pharmacological interventions like amyl nitrate, hypotensive phase, tachycardia, transient arterial occlusion, etc. we have seen. Now, this is something which you have to keep in mind when you are describing. This is not really dynamic auscultation, but it is when you are describing atrial fibrillation, always describe, when you're describing mitral stenosis murmur, always, and there is atrial fibrillation, do not forget to look into the effect of the MDM, atrial fibrillation on MDM, and what is the important thing about the duration of the murmur. Remember that in the long cycle, if you have a long murmur which persists up to the first heart sound, it tells you that the mitral stenosis is severe. Of course, you have first heart sounds which are classified as type 1, type 2, type 3, but this is not really important for the exam. It will confuse both you as well as the examiners. So this probably you don't have to talk about the sounds, but the duration of the murmur, the presystolic accentuation, and the in the long and short cycles of atrial fibrillation are important, and we should not forget to describe it when you're describing the murmur of mitral stenosis in a patient with AF. Now, one question is that can a hepatojugular reflex can be used as a dynamic auscultator maneuver? Because as you know, hepatojugular reflex, which is called as Pasteur-Rondeau maneuver, can be used to elevate to determine the left atrial pressure. Pulmonary capillary wedge pressure is more than 50 if the hepatojugular reflex is positive. So a normal pressure TR will appear only during inspiration, but if you want to elicit it, you can elicit during abdominal compression. So a low pressure TR you can elicit by a hepatojugular reflex, a combined hepatojugular reflex and dynamic auscultation. The TR murmur, if it fails to increase with inspiration, then it is severe RV dysfunction. It can be an organic TR or Epstein's anomaly or associated with tricuspid stenosis. So if the TR murmur does not increase with inspiration, these are the possibilities. Any maneuver to help differentiate the MDM of mitral stenosis with Austin Flynn murmur? Yes, the isometric hand grip will aggravate the Austin Flynn murmur. In mitral stenosis, unfortunately, the murmur response is variable. It is not that it will decrease, it will vary. So definitely an aggravation of this Austin Flynn murmur, AR murmur, or a mid-diastole in severe AR will tell you that we are dealing with a Austin Flynn type of murmur. And once again, looking at the HOCM with this MPS, we have already told in static LVOT murmur increases, HOCM murmur decreases. So coming to the last, what is the future of dynamic auscultation? As I told at the beginning itself, you have this with you, handheld ultrasound. Perhaps there is everything is, at least as far as valvular heart disease, to some extent, everything is given to you. But I suppose you can combine dynamic auscultation with this, which is called as dynamic echocardiography. You can use the principles of dynamic auscultation with echocardiography and call it dynamic echocardiography. And this can be due to Valsalva maneuver. It can be a squat echo. It can be a hand grip echo. All this can be done with, so it has not lost dynamic auscultatory or dynamic features are not lost only with auscultation. It can be done with a handheld echocardiogram. So to conclude, posture, respiration are the essential parts of auscultation. Second heart sound is primarily assessed, and how it moves are important for the pulmonary circulation. For the left heart assessment, isometric hand grip. For the right heart, it is the respiration. And squatting and Valsalva maneuver is used judiciously to differentiate the dynamic forms of, and Mueller's and amyl nitrate are all obsolete. And clinically, dynamic auscultation will help to differentiate AS and HOCM, AS and MR, MS and Austin Flint, and PS and small VST. I forgot to mention that, but this is only with amyl nitrate or phenylephrine. PS murmur will accentuate, VST murmur will diminish. And if with phenylephrine, PS murmur diminishes and VST murmur accentuates. Thank you very much. Now I'm open to all the criticism and questions because a lot of points are debatable to some extent.
Thank you, sir, for the excellent teaching. I would call it as a teaching program for the dynamic auscultation for all the residents of DM and DNB. And sir, if given a situation other than HOCM and MVP, if asked in exams, which other lesions it is the most important to do a dynamic auscultation?
Other than HOCM
and mitral valve prolapse, sir.
Yeah. So the first and most important, of course, is HOCM and MVP. The second, apart from this, the important thing is the if you take the right-sided murmurs, it's tricuspid regurgitation. If you take the left-sided murmurs, it is mitral regurgitation. And of course, to some extent, most important is, of course, aortic regurgitation. So these are some of the things which you can elicit by dynamic auscultation.
And sir, is it possible that to do a dynamic auscultation to see whether the outflow tract murmur in the aortic area is because of severe AR and not because of an organic AS? You told in one of your slides that if there is isometric hand grip.
Isometric hand grip is one of the things which can distinguish between the two, between aortic regurgitation, which is largely due to flow, and aortic regurgitation, which is due to the valvular component, and to distinguish. So they have an ejection systolic murmur, but of course we rely on other clinical findings like peaking of the murmur and other things.
Again, the most important, one of the important point which you raised also was unmasking of S4 in aortic stenosis.
Yes, very important.
That's very important one. And the other point which you very lucidly and very masterly elucidated was the beat-to-beat variation of mitral stenosis murmur in patients with atrial fibrillation and MS.
Yeah, that has to be told. The PGs yes, have to tell it in the exam because mitral stenosis murmur description is from undergraduate level is the same. But yes, what is important for at our level is, of course, the murmur, then the flow. You have to elicit the murmur in presence of atrial fibrillation, whether the murmur is behaving, there is pre-systolic accentuation, and how severe the mitral stenosis is.
Many times the students are caught in a catch-22 situation wherein the patient, when we describe that the JVP is a little bit elevated and he is in sort of failure also. How, in what way that student should explain about the non-performance of dynamic auscultation in such situations?
Actually, in such situations where the JVP is elevated and the patient is in heart failure, the murmurs will start behaving a little differently because the right ventricle is already reaching its height. And so perhaps the right-sided events may be difficult to elicit. For example, I'll tell you, tricuspid regurgitation we classify in mild, moderate, and severe. And in severe tricuspid regurgitation, the murmur has no effect. I mean, the inspiration has no effect. So dynamic auscultation will not. But the same thing will go to the left side also. So left side events are also damped where there is increased JVP and heart failure. And that's an important point that you have raised, that once there is heart failure, dynamic auscultatory changes will not be so much evident as because you cannot change the preload, afterload that much in patients who are already on the upper limit of the static curve.
So if they don't perform dynamic auscultation, then that E should be okay.
It should
The
be all
examiner
right,
should be okay.
but these are the cases in which GVP is markedly elevated. I mean,
Yes.
they are in gross heart failure. Like sometimes you get patients with multivalvular disease. There we don't have to. In any case, the 90% of this dynamic auscultation rests on HOCM and, of course, mitral valve prolapse and very few other conditions, like, as I said, right-sided events. Pulmonic stenosis, of course, I have not shown everything in detail, but there also to some extent inspiration plays a part. In congenital heart diseases, it's very important to talk because the septum is intact if there are changes in inspiration.
Any questions? Then let me see the chat box. There are some questions. But not many questions from the students they have posted. I think I think they will go and read again and get back to your lecture again on YouTube, and they will be in a better position to understand dynamic auscultation as well as answer the questions they're asked in exams.
The important thing about dynamic auscultation is not just the murmur. So that anybody can answer about HOCM. The important thing is the circulatory change.
Yes.
To tell you very frankly, I should not use names, but if you listen to Dr. Tarakan, Jagan Mohan Tarakan, he will always insist on change of the circulatory hemodynamics and then the effect on the murmur.
Yes.
And that is more important than just to say that the murmur will increase or decrease.
Yeah, and we forget about the effect of dynamic auscultation on added sounds. So that is also also becomes very apt and to be described during the exams.
Very true.
Mohit, any comment or questions?
Yeah, I lost.
Actually, I sat with Girish.
There was some urgent call from the hospital, so I just messaged Girish. But anyway, sir, it was absolutely a terrific lecture, especially the phenomena of dynamic auscultation. You were explaining the combinations of the squatting and that phenomena. They're very, very nice, and this needs to be revisited and listened again to just.
No, the best part is I think sir very clearly told that it should not be done in isolation. You can mix and match and combine one or two maneuvers together to get a best effect of the hemodynamics as well as the heart sounds and the murmurs.
Correct.
More so, Girish, as you have seen that sir has very givenly nice mantras, like simple things to remember that. Finish with the Valsalva and all squatting murmurs will increase except focus. So these are small things that if our residents are remembering, life becomes more simple and easy for them. So I can't thank you enough, sir, for this great and terrific lecture. And we will be carrying on this series. This lecture will be uploaded on the YouTube channel by in a couple of days. And I would strongly suggest that please reread this. I would also suggest reading Dalman-Steen and for this particular dynamic auscultation. And there is one chapter in the postgraduate cardiology read from SGPGI that is also very good. Simple.
Very good chapter, yeah.
So you can go ahead with this. Any other reading that you suggest, sir, to complement this, sir?
Books, you mean?
Yeah, any particular chapter or any article for dynamic auscultation that you would like to suggest to our residents, sir?
As you said, the book of dynamic auscultation itself, that book is good. And postgraduate, that series is fantastic, for everything, for auscultation. So that I think all the postgraduates should read. I just tell you that there are a few chapters in that which are extremely good, whether it is dynamic auscultation, continuous murmurs, JVPs, etc. So many things are put together and done very well. I don't know the present CSA update. I have not gone through that, but this was a very good effort.
That is the only unique masterpiece that has been there. No other.
Yeah. And natural history of AR, MR,
yes,
and to some extent MS. All these are very nicely given in that book, and that can be there.
So thank you so much, sir. Thank you so much as always. It's always a pleasure. You're such a great teacher, such a great human being. It's always, we can't thank you enough, and so humble. Always, sir, will be happy. And sir, we are not going to leave you. Let me tell you, this will bother you. This is your own family, and we will keep on, because every time we listen to you, it's a great learning for all of us.
Yeah.
Thank you so much.
Girish and myself, we thank you on behalf of Delhi.
Actually, I was with Girish only once as an examiner in DNB. And in fact, I learned a lot from his questions. We were just, he's also equally, he can be equally clinical. He's an interventional cardiologist through and through, but he can be equally clinical. I'm sure all of you are. And that is what is the beauty of the present generation. That though being highly interventional, they are also equally good. And this happens in academic institutions like
it's beautiful. Thank you
so
so
much. The question of learning never ceases, sir. The day you feel that you know everything and stop learning, then that is the day of your doom, sir.
Yeah, that's right. Thank you so much. Thank you all our fellows and our colleagues who have joined, and thank you Intas for providing us this platform. Next week we are going to come again with a very wonderful lecture. Most probably it will be on hemodynamics of heart failure, and we'll catch up soon. Have a safe weekend, safe week, and just enjoy the academics. Thank you so much, everybody. Good night.
Thank you, sir, and good night, sir.
Good night.